So just a bit of a background. So we saw a 77-year-old gentleman who has a background of hypopituitarism due to a pituitary adenoma that he was first diagnosed with in 2011. He was largely asymptomatic until 2016 when his symptoms got worse. So his main concern was sort of just feeling very fatigued, quite nauseous at the time. And therefore he was started on a full hormone replacement therapy. So levothyroxine, growth hormone, libido, and hydrocortisone as well, with the dosages shown there. Now, so he had an MRI performed, and this was the MRI that was carried out in 2019. So an MRI performed in 2019, so after his symptoms have been getting worse. You can see the pituitary in the center, with the carotids on lateral aspects, and also the tunica ocelli, and just above the pituitary is the optic chiasm as well. In the MRI report, it showed that there was the optic apparatus wasn't affected at the time, and he wasn't getting any sort of visual symptoms in 2019 either.
Okay, and this is in 2019, yeah?
Yes, yeah.
So how big is that tumour is, everybody?
Something else. 2 centimeters.
Ah, well done, Amina. Okay, yeah. You've got it there. Yeah. So yeah, it is about 2 centimeters. In fact, you've got it on the next slide.
Yeah. So on the next slide.
Say that again. Yeah.
Yes. So it's pretty big. So yeah, as you can see, 2 centimeters roughly by 2.
But you can see nicely, everybody. Just go back one slide. How you point out the optic chiasm, which is this bit here, is actually not compressed. This patient won't have a visual field defect or a bitemporal heminoma that we worry about. It's just that huge tumor. It's not huge. It's quite big, I guess, but it's not. Well, it's affecting his hormones, isn't it?
Yeah.
Okay.
Yeah. Okay. And at the time, because he wasn't getting any sort of visual symptoms, and his as Professor Mary was saying, his his optic chiasm wasn't being affected, he decided to repeat the MRI scan in a year's time and see where it went from there. This is just a quick recap of the pathophysiology of sort of hypopituitarism. So this is the anterior pituitary with all the cells that produce different hormones. So you have the thyrotropes producing TSH, you have cells producing ACTH, the sex hormones, and also growth hormone as well. And what's happening here is that there's an adenoma that's expanding, and it's pushing the other cells to the side of it's compressing the other cells, and therefore it's affecting the hormones that's being produced by those other cells. And that's why he's being put on the full hormone replacement therapy, so the levothyroxine, growth hormone, sex hormone, and hydrocortisone as well. This is just a bit of a background as to his other medical conditions. He represented in 2020 with sort of worsening fatigue and also some double vision. On cranial nerve examination, he said he had a left horizontal nystagmus, but he has been known to have sort of a long-standing squint. Importantly, his visual fields were normal in 2020, and they performed an MRI, which also showed no compression, which I'll show you the MRI just in a moment. So on the left side is the scan I showed you previously, and on the right side is the 2020 scan. So as you can see, the dimensions have increased and it's grown bigger. It still hasn't compressed the optic chiasm, which is just, again, superior to the adenoma. But at this point, it's getting quite close, and I think it discussed in the MDT, they're a bit more concerned as to how much it will be growing in the future. So because he is 77 years old, it was discussed with the patient, and the decision was made to surgically remove it now before it sort of grows, essentially. And this was just a few details for about the surgery itself. So it was a esophageal tumour. Mr. Nair and Mr. Grant were sort of in charge of the surgery. And yes, the main plan.
Just read through it. What you say to it small there? Go on.
So the bilateral approach was taken. Left-sided superior turbinate was partially taken, and the middle turbinate was preserved. Sphenoidectomy was performed as well.
So they drilled a hole through the bone, basically. That's sphenoid. Okay.
So yeah, the dura was open, and so samples were taken for histology, and the dura edges were coagulated as well. They put in some lysip into the cavity over the dura.
Because it's quite big, I think, to make it not leak. Because sometimes you get a CSF leak if they take such a big tumour out.
And the plan after the surgery was to continue OBS and follow up in sort of endocrine and outpatients for ENT as well.
Yeah, so we've got CSF leak if it's like dripping CSF from their nose. Darby's insipidus, because of course that's something he hasn't got. Although he's missing all the other hormones, sometimes when you poke around the pituitary, you get Darby's insipidus. So as they call them, sodium issues. So that's where to keep seeing the patient basically every day after the operation.
And an MRI was to be performed again just post-surgery to check what's been done already. So left side is the tumor at its largest, and then just before the surgery, and on the right side is the post-surgical outcome and it being removed. So you can see here you have the pituitary stalk with I think that's a sinus.
That's
as well.
So, yeah.
And also the optic chiasm, which is not, it's not being compressed though.
No longer threatened.
Yeah.
Okay, that's a really good outcome, isn't it? So,
yeah.
Because it was right around the carotid. Any thoughts or questions about that from anybody? Amazing result, really.
So post-surgery, it was a very successful surgery, and he was discharged for outpatients follow-up. I think he was also switched to a reducing dose of prednisolone instead of his hydrocortisone, and he was reviewed in clinic yesterday, and he was presenting with he presented with sort of further sort of lethargy, malaise, and nausea as well, and he found that it was worse after sort of reducing his prednisolone to 1 milligram daily. So it's been around, I think it's it was 4 to 6 weeks post surgery, and I think his prednisolone had already been reduced to 1 milligrams. So we felt that this might have been a cause for his symptoms, but we'll come on to that in a second as well. In addition to his symptoms, we also received the histology report as well for the removed tissue from the surgery. So it was a pituitary lesion, which was measuring sort of 15 by 15 by 3 millimeters. This is quite a detailed description of the histology, but I think most importantly, at the end of this report, it showed that there was that the pituitary adenoma was actually a corticotroph adenoma, so it was expressing ACTH, and at this stage we were concerned as to whether it was actually maybe a corticotroph adenoma causing Cushing's disease instead. And so therefore 2 tests were performed just to further investigate. So a synactin test was performed to just assess the sort of adrenal reserve after the surgery, and it showed that it was normal because the cortisol increased with the ACTH applied. So that's a good thing. And the overnight dexamethasone suppression test was also normal as well. So it shows that he didn't have Cushing's disease.
Did he have these tests?
Why did he have these tests? That's a very good question. Do we tell him?
I think he had, for the dexamethasone suppression test, because they've they saw in the histology report that was a ACTH producing adenoma. They thought that maybe this adenoma was growing and therefore it was growing and could be a cause of maybe Cushing's disease.
Yeah. So just to explain, so you know that he's been on hydrocortisone for years, for 10 years at his local hospital. So it looks like on that synaxin test that actually he has a normal adrenal reserve, which means he's he is definitely making some ACTH, because otherwise he wouldn't have a starting cortisol that's quite good. It'd be 0, right? So he's no longer, since his operation, he's no longer hypopituitary. So it looks like removing that tumor has actually resulted in de-repression. That was you know how the bone around the sella turcica, the tumor is squeezes the cells. So if that's come out, then he's normal. And because we saw that he had corticotrophs, as Michael mentioned, if he's got corticotrophs that are making cortisol, then in fact he would have had undiagnosed Cushing's. But he didn't. I mean, he wasn't thin, I must admit. But so we do a DEX suppression test to check whether he's got clinical Cushing's, and since he definitely hasn't, because his cortisol is suppressible. If you've got a tumor that makes ACTH, then it's unsuppressible. So you give him dexamethasone, the cortisol will remain high, and then you know it's Cushing's. So because we had the staining, it looks like although it was making ACTH in the tumor, it wasn't secreting it, which is why he didn't have clinical Cushing's, and therefore we called it, and the histologist wrote this down here, the possibility of a silent tumor. In other words, it's got ACTH, but it's not making it, not secreting it, and that's a silent corticotroph adenoma, which is obviously better than a Cushing's one. I just thought, having seen that, I thought we'd be absolutely making sure he hasn't got undiagnosed Cushing's, because that has obviously long-term morbidity. But luckily, he's not got Cushing's, and he hasn't even got adrenal failure, but he feels rubbish on his only 1 milligram of pred.
So we also performed some blood tests as well to assess, and here they are.
So move this out of the way so that people can see his. Oops. Yeah.
So his on the 9th of July was post-surgery, and it showed that his and this was he wasn't taking any prednisolone at the time, so it shows that his adrenals are functioning well. And yesterday on the 12th of August, it showed it was low, and that's because he's taking his prednisolone at the moment. So because he's taking exogenous, the endogenous cortisol would be low. I guess another interesting thing to see is that his estradiol and his testosterone are also quite high, so it may need some adjusting his medications.
He's taking testosterone. He says he has a monthly, monthly injection. So we have to adjust that dose downwards, because what's happening obviously is he's having an injection of testosterone, and testosterone is isomerized to estradiol. So that'll give him, gynecomastia and things if we don't adjust the dose downwards a bit. So he's hypopit still, looking at the TSH, so he needs thyroxine, possibly. We know that he doesn't need cortisol, although when you give him pred, he suppresses it. So we have to wean it really slowly, because if you, as they did, weaned it too quickly, he just felt terrible, because he's used to a high level, firstly, and secondly, although his adrenals respond, his pituitary needs to be making ACTH, which it needs a very slow wean, and that was too quick, I think, which I felt a bit useless.
And as Prof. Miran mentioned, so we're going to be weaning off the prednisolone according to this protocol here. So as opposed to weaning off over sort of four weeks, this goes on actually to 24 weeks, and so you can see that he's sort of initially on 5, and you can stagger it down to alternate days of 5 and 4, and so on until he stops taking it, and this hopefully should improve his symptoms. I think
going below 3. See, the 3 is the dose at which, if you have no adrenals, you need 3. So going below 3 is hard work, and you'll notice it's really slow. So he's on 3, and he's got 1 day of 2 underrun, and then back to 3, and then next week he's on 3, and he has 2 days of underrunning. Because when you underrun people, they feel a bit hopeless. But when that happens just for a day, it stimulates the corticotrophs to make a bit. And this is the only way to do it properly, really slowly. and that will minimize their feeling of hypopituitarism. We know he's safe. Okay, he's definitely safe, because if you stop it dead, while he'll feel terrible, he won't have a crisis because he has got enough cortisol to get by. But he needs to be able to make more at times of stress and things. Most hospitals use hydrocortisone rather than prednisolone. Okay, good question from Amina. How common are silent corticotroph adenomas? So more common than Cushing's is the answer. So we take out a lot of non-functioning pituitary tumours. Most of them stain for LH and FSH, and they're not secretory. So a large majority of non-functioning tumours are gonadotroph staining. All the others tend to be secreting. If you have a prolactin staining tumour, it will be a prolactin making prolactin. ACTH, about probably 90% are non-functioning, because the 10% who are Cushing's present with Cushing's. They don't have a tumour. They're very small, but the Cushing's makes them come in. So just to say a bit about this, so hydrocortisone is a very old drug because it was launched in 1949. And I'm just going to remind people that it's an essential hormone, essential drug for any healthcare system defined by the World Health Organization. Okay, and it used to be very cheap, 70 pence per month supply, and then a few years later it's £50. So it went up in cost a lot. And this is the political bit, which is the price of hydrocortisone cost the NHS £60 million a year instead of about 400,000. Okay, and so because of that, we at Charing Cross in 2014 started using prednisolone instead of hydrocortisone as replacement. And it was a financial decision, because you either spend £400 on hydrocortisone or £2.30 on prednisolone. And we then started to find it was better, more advantage. It was you take one dose in the morning and it would last all day, and it was £2.30 a month instead of £400. So although the initial driver for this was financial, we then set up this blind randomized controlled trial of hydrocortisone and prednisolone, which is ongoing and will report in about 2 years, the blind part, but we've got an open label study that's got quite a lot of data and it looks pretty reasonable. Now I'm just going to end with this, and that is that when we started doing this, because we made hydrocortisone for our study, the company that made it for us have launched it on the open market, and the price of hydrocortisone has come down now because of our study. And so it then became clear that there was some competition irregularities, let's call it, or bribery and corruption is the other way of saying it. And basically they were keeping the price really high. So I've set this up because this is the way to stop this happening. It's happened to lots of other drugs, by the way. And so I've been to various groups, and this is the way to do it. And that is for the NHS to make its own drugs, not new things, just the old ones that we need, like hydrocortisone, thyroxine, insulin, simple things. Do you know the UK doesn't make any insulin? So we need to make some of that. And so I've set up a petition because I need 10,000 people to sign it. I've only got 300 so far. It was only just, you've got 349 now. If you want to find it, there's a link to it from our website. And if you go to Imperial Endo, you'll find it there. I've got this link called price gouging. And then it explains a bit about what we've done and how we've proven that you can cut the cost by doing this. Because the government up till this point was saying competition will work and you don't need to do anything. But we've proven that it just went up and up and up and up. Because if you look, this is actually the live website. So if you look at the price of hydrocortisone, it went up and up and up and up. And then we started our study just about there, and it came down, 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 down. But until that point, it kept on rising despite years and years of people saying it's too expensive. So that's why we need people to click that button, sign the petition, and then I hope you go over 350. Okay, I want to stop talking and see if there's any other questions.